Hello, we are from the task force of UCARE LevelUp task force. We are going to talk to you today for the causes of chronic urticaria, the research for relevant conditions that modify disease activity. My name is José Ignacio Larco. I work at Clínica San Felipe at Lima, Peru. I am an allergologist, and I am here today with...
This is Bahar Sevimli Dikicier. I am a dermatologist from Sakarya, Turkey. I am the head of the university hospital in Sakarya Dermatology Department and the fifth UCARE Center of Turkey. We want to start with our first question, which I will be asking to José. What are the expected comorbidities to be faced together with chronic urticaria, José?
Bahar, thank you for the question. It's nice to be sharing with you. Well, the comorbidities that we usually see at chronic urticaria are atopic comorbidities like rhinitis and asthma, psychiatric diseases, thyroid diseases, infections, autoimmune diseases, celiac diseases, and chronic induced urticaria. We are going to have another level up in video with talking only of comorbidities, but I am going to talk about some of them that we have seen that can be related with going worse your chronic urticaria. So in this study, Sanchez Borges and all show us, they do a research of the most prevalent diseases in patients with chronic urticaria. As you can see, psychiatric diseases are very common, as well as atopic diseases, thyroid diseases, hypothyroidism, and hypo and hyperthyroidisms, as well as some patients with euthyroidisms, rheumatic diseases, inflammatory diseases, osteoporosis, diabetes, malignancy, hypertension, and obesity. The studies are not so conclusive, but we have some of them that show that they can be comorbidities with chronic urticaria. Also, a systematic review by Cornelier in 633 children noted that common comorbidities in chronic spontaneous urticaria in children were psychiatric disorders, low vitamin D level, atopy, thyroid anomalies, Helicobacter pylori. In another study of Seungri in Korea, they found in this demographic study population of over 4,000 patients using controls and urticaria patients that comorbidity of atopic diseases was very frequent. And the prevalence of asthma, allergic rhinitis, and atopic dermatitis was much higher in the group with chronic urticaria, and it was statistically significant. Although CU is not considered an expression of IgA-mediated allergy disease, IgA-mediated allergic disease usually do not aggravate CU symptoms, although in the outpatient clinic you can see that some patients with maybe dermatitis, atopic dermatitis that is flare up could worsen the CU disease. But what we have noticed is that CU is very common in allergic and atopic patients. So autoimmune diseases in CSU patients is very, very frequent. This study of Colquier shows how prevalent are the CSU, how prevalent are the autoimmune diseases in CSU patients. Here we found the prevalence in general population, and here we have the prevalence of these diseases in urticaria patients. And as we can see, thyroid disease is more frequent in CSU patients, as well as some other autoimmune diseases like vitiligo, rheumatoid arthritis, autoimmune gastritis, diabetes mellitus, and others. Celiac disease here is in general population, but there's also a very good study in children that it has been noticed that almost in the group of CSU patients with in children with CSU, the prevalence of celiac disease is almost 5%. So it's very good to study celiac disease in children when you have chronic spontaneous urticaria, and you have also another symptom that can tell you that celiac disease might be the answer. So autoimmune comorbidities associated with being female and family history of immunity. Patients with angioedema have higher rates of comorbid autoimmune disease. Presence of autoimmune disease in CSU is associated with higher disease activity. Also, comorbid autoimmune disease are linked with having type 2 autoimmune CSU, and type 2 autoimmune CSU is defined by positive autologous serum skin test, positive basophil activation test, positive basophil histamine release assay. And these markers of autoimmune disease are associated with also bad treatment or poor treatment response to omalizumab. Here is just to see how these are the most frequent autoimmune diseases around chronic spontaneous urticaria. And psychiatric comorbidities, in this study, we can see how prevalent are the different psychiatric diseases in patients with CU. And sleep-wake disorders are very common, anxiety disorders, and mood disorders, and others. We are going to see when we talk about triggering factors that psychiatric disorders are related with worsening of CSU diseases. It's important to know that chronic urticaria is it's much better treated when we have multidisciplinary teams that work not only in dermatology or allergy, but also rheumatologists. As you can see, psychiatrists will help a lot to have a very good, to have our patients well. So, Bahar, I want to ask you a question after we have talked about comorbidities. What are the laboratory and imaging tests that should be done to diagnose CU?
Thank you, José. There is a list published in the guideline of classification, definition, diagnosis, and management of urticaria, which was introduced by the common international committees. There is this list is made up for the aims that must be aims doing for the diagnostic workup in patients with chronic spontaneous urticaria. The list is summarized with the 7 C's. The cause order, the second one, cause, is the topic of this video. What do we do for our chronic urticaria patients according to this guideline? We may summarize this. Should we change the slide, Jose, please? May I request the slide? Thank you. It was recommended that a thorough history, physical examination, basic tests, and the assessment of disease activity impact and control on life of patients should be done in all chronic spontaneous urticaria patients. Physical examination may be a challenging factor regarding seeing the wheals of the patients, because urticaria is a waxing and waning situation. At the time of examination appointment, the patient may not have any clinical signs. but the pictures of the patients would be very helpful for us. This is a routine practice for all the allergists and dermatologists and all around the world. We may use the photographs. So what do we mean by saying basic tests? A whole blood count, C-reactive protein level, and or erythrocyte sedimentation rate in all patients, and in specialist care, including allergists or dermatologists, total IgE and IgE anti-TPO, which is a thyroid autoimmunity marker, should be screened. And further diagnostic testing may be performed as indicated for individual patients because, as José told us, we should evaluate the patient as a whole, not only seeing the urticaria, not only seeing the itching or angioedema or the patient. There is a more detailed list published in the guideline of Brazilian Society of Dermatology. It recommends the similar levels for the diagnostic workup, but some detailed ones are explained here as associated systemic diseases, specifically including serum tryptase levels, which shows us mastocytosis condition of the patient, because it is a differential diagnosis disorder for the urticaria and angioedema patients. Presence of associated induced urticaria, inducible urticaria types, usually associated with chronic urticaria patients. This should be kept in mind and should be searched for the patients. There is a last item, as mentioned others, like histopathology of skin lesions. This is a test of differential diagnosis for the diseases like urticarial vasculitis or collagen diseases like systemic lupus erythematosus. Should we exclude the malignancies in urticaria patients? It is advised to do the malignancy screening depending on the patient's history. Plasma D dimer levels are a new and current topic for the diagnostic workup in urticaria patients, because it has been published that D dimer levels are higher in patients with active chronic spontaneous urticaria, and decrease is observed after treatment with omalizumab. But the recommendation on measuring D-dimer levels for all patients with chronic spontaneous urticaria is still debated. And a rather new investigation from Emek Kocatürk and colleague Dr. Gratan was published with the title is Chronic Urticaria More Than Skin Deep. They searched the chart data of chronic urticaria patients to investigate the associated other systems disorders. Cohen's syndrome, which is known as allergic myocardial infarction, hypertension, and some list of diseases including central nervous system, the lungs, the bronch and the lungs, and gastrointestinal system and muscle skeletal system are found to be worth investigating or searching for individual or for some sort of patients of chronic urticaria would be beneficial. They have completed in the last. So I want to ask José again, what are the triggering factors for chronic urticaria?
Bahar. Well, after we have seen some comorbidities and what tests we should do, there are also some situations that and diseases that can aggravate patients with CU. These are infections, stress and anxiety, drugs, physical stimuli, foods. We are going to talk about these ones now. So infections are related with causes of facilitate with cause or facilitate as a cause or facilitating factor for initiation and perpetuation of chronic spontaneous urticaria. Also, we have seen that infections are a causal factor for acute urticaria or acute flares in CSU patients. Mechanisms for activations are not clear, although activation of mast cells by inflammatory cytokines can be one of them. The different infection triggers, well, we have viral infections that is a very common cause of acute urticaria in children. Dental or ENT infections like bacteria, streptococci or staphylococci, the presence of tonsillitis or sinusitis or dental focal infection have been described as a cause for worsening of chronic spontaneous urticaria. The studies are small and the results are not so clear, but if we have a suspicion of it, and we should treat it. Gastrointestinal infections of bacteria. Maybe one of the most studied infection is Helicobacter pylori, and it seems to be that the different systemic effects that has this gastric infection, that it goes from vascular, autoimmune, and skin, it can be related with the CSU. There are multiple studies that go in favor and some of them that go contrary. The remission improvement rate is nearly doubled when you treat when Helicobacter pylori is eradicated in a patient with chronic spontaneous urticaria. So we should treat it if the patient has it. Yersinia pestis, where there are some cases described of persistent yersinosis and the remission of CSU after treatment. Parasites, also a very common parasite studied is Blastocystis hominis, and some studies support the treatment of patients that have chronic spontaneous urticaria and Blastocystis hominis, as well as Giardia lamblia. So we should study parasites maybe in countries like mine, where the frequency of parasites is very high. Fungi, Candida doesn't play a significant role in the last studies published. Stress and anxiety, as we have talked a little bit before, have increased the levels. Patients with CSU that have increased levels of emotional distress usually have a worse disease activity, and this is mainly because of anxiety, depression, and somatoform disorders. Emotional and physical stress also sometimes is relevant for the development of symptoms like cholinergic urticaria. The mechanisms are still unclear, but three of them that I will enumerate is, for example, basophils of CSU patients activate more readily with adrenocorticotropic hormone and corticotrophin releasing factors. There is also a link between brain and mast cells within the via C fiber sensory nerves that are involved in worsening of skin disease in CSU and atopic dermatitis related with stress. And stress also induced release of substance P and CGRP by sensory cutaneous nerves, leading to itching and mast cells activation via several receptors. Also, we have the scratch itch cycle, which is related with stress and anxiety. So physical stimuli, I am only going to mention it because we have had and we are going to have more about chronic induced urticaria. But it's important to know that patients with chronic spontaneous urticaria usually, or not usually, but lots of the times they have also a chronic induced urticaria associated. and this stimuli that can activate the chronic induced urticaria, well, we are going to worsen also CSU. For example, friction, pressure, solar exposure, cold, heat, and exercise. Drugs, there are some drug allergies that can produce urticaria. Well, also, there are food allergies that can produce urticaria. We're going to talk about food. And in this case, when we are suspicious of a drug allergy, the indication is to change to another agent and then see how the patient goes with his urticaria. But there are also some drugs that are causing non-allergic hypersensitive reactions that will aggravate pre-existing CSU. For example, NSAIDs are the drugs that are more common in these cases. So patients with chronic spontaneous urticaria should avoid using NSAIDs. And in patients that have angioedema, we have to look for oral contraceptives and ACE inhibitors, which can be the cause or can be aggravating this situation. Food as triggering factors, well, this is really maybe one of the most common questions in the outpatient clinic in patients with chronic spontaneous urticaria. There are several studies about this. Food allergy is present almost in 10% of patients with chronic spontaneous urticaria, but rarely is the cause for the chronic spontaneous urticaria. Sanchez at Colombia realized food challenges in CSU patients and control groups, finding that only 1.2% of CSU patients and 0.7 control patients had similar sensitizations and positive food challenges. There are also some studies that have noticed that single foods are not likely to be triggered in patients with CSU. This may be related with combination of foods, and we're going to talk a little bit in the next slide. We have to have in mind that there is two allergies that can be cause of CSU patients that are maybe alpha-gal allergy related with meat, because here the symptoms are very delayed, so you maybe do not relate with the ingestion of the meat, and also anisakis allergy, which is a nematode of the fish. So it has to be suspicious in places where there is anisakiasis. Our immunologic reactions like celiac disease, as I have talked before, are described as cause of CSU. So, several studies present results demonstrating that group of foods may worsen CSU. These foods usually are alcohol, food additives, seafood, certain vegetables and fruits, red berries, citrus, fermented foods. It's important in patients that are very suspicious of foods to do diaries, to do open provocation tests, and to think about elimination diets. The elimination diets that are described are pseudo-allergens-free diets, low histamine diets. We have seen that there are partial remission rates after 3 weeks in patients that are doing diet, almost in 1/3 of the patients, but most of the studies do not have control groups. Pseudo-allergen reactions are generally related to dose or to the quantity of the food and to the frequency. So it's not necessary to do a strict diet. Food allergies alone by themselves do not appear to be CSU triggers. Ingestions of excess histamine in food are also related in some studies with systemic symptoms and cutaneous symptoms. So patients can have worsen the pruritus, angioedema, wheals, and also systemic symptoms. So foods with high histamines are seafoods, fermented foods, plant foods. Low histamine diets can be helpful, as well as pseudo-allergenic diets, but they are not so clear, the results. But Bahar is going to tell us about something about diets. So I wanted to ask you, Bahar, is diet a critical issue among CSU patients?
And thank you, Jose. Actually, you told the most of the information about food and urticaria existing in the literature. There is a large review including 20 studies over 1,050 patients, which try to express the importance of food in case of urticaria. Complete remission with pseudo-allergen-free diet, low histamine diet, or fish avoidance in conjunction with antihistamine therapy yielded only in the 5% of the patients. Partial remission is achieved in 37% of the subjects. The highest rates were reported in a median duration of 3 weeks for pseudo-allergen-free diet and low histamine diets. As José told us, benefit of diets in chronic spontaneous urticaria has evidence only in individual patients. A little bit previous, but a very detailed study is also available in the literature, which was conducted in Italy. It is a double-blind, placebo-controlled study. Double-blind, placebo food tests could be done for these patients, and only 16 of the more than 800 patients with a clinical history related to food and both positive double-blind tests has shown an improvement in urticaria during the food additive-free diet period, which I mean they gave the patients first a food additive-free diet, and then according to their complaints, according to the scores of their urticaria, they have planned double-blind, mixed and single food challenge tests, and they concluded with a statement saying in the refractory chronic urticaria and angioedema that do not respond completely to Ashpir antihistamine therapy cases may benefit from eliminating the diet. These are the foods we are talking about. The pictures summarize them very clearly. That includes all the foods we may consume. So this is a hard topic for urticaria patients because benefit of eliminating diet is very limited, and a very long period of time is needed. Minimal 3 weeks of avoidance of suspected food is needed to reach a result. There is another study I want to tell. It is a little study from Turkey, from a state hospital with a dermatologist and dietitian did the study. They tried to show the Mediterranean diet effect on the chronic spontaneous urticaria patients, and they concluded that they have a nice schedule showing the Mediterranean diet score affects positively the urticaria activity score in the patients. They did this study with a questionnaire. It is asking the amount of Mediterranean diet elements, members in their diet, and they concluded that adherence to Mediterranean diet may be an independent factor that may lower the occurrence of CSU and also reduce the severity of CSU symptoms in patients. Maybe it is worth studying further. Thank you.
That's true. So, just to be finishing and wrapping up, Bahar, I wanted to ask you, what are the things that patients can use to relieve CU themselves?
Of course, first, patients must know that we can treat urticaria. We can make patients live their life without losing the quality. But sometimes urticaria is going on and on situation, and each can be relieved at home by some minor behaviors, like avoiding overheating. This may be done with cool water shower or staying in air conditioning. Some simple antihistamine, anti-itch medications or calamine lotions, and preventing drying skin makes a good result for itching. Some other precautions may be cold compresses, but not too cold, like putting the ice directly on your skin, because direct applying the ice may trigger your hives. Wearing loose fitting and good fabric textured clothes make you more relaxed by reducing friction. The choice must be cotton or smooth, lightweight rayon type fabric. Wool, linen, and denim fabric must be avoided. And another important point is not scratching, because there is a scratch itching cycle. It may be more than tempting, but scratching the skin actually make the hives and the itch worse. Some other a diary, as we talked about the elimination of triggers, or especially for eliminating food. A diary may be helpful for other factors, including, for example, medications which you are not aware. Maybe you are very used to using it. It may show the daily habits that you aren't aware in your daily life. A diary helps you identify triggers, and you stay away from triggers. And a sunscreen before going outside would also be helpful. It's recommended for urticaria patients. Thank you very much. I hope you all enjoyed it. I hope it will be helpful for all. José?
Yeah, thank you very much for your attention, and it was nice to work with Bahar and show you this UCARE LevelUp task force video for our colleagues. See you in the next video. Bye.
Yeah, bye.
Okay.